Hello, everyone. Good afternoon or good morning, depending on where you are. On behalf of the Duke-Margolis Center for Health Policy, I'm Mark McClellan. I'd like to welcome all of you to today's event on Advancing Hepatitis C Elimination, a Coordinated National Approach. Whether you're here with us in person, and thank you all for coming out, or the many people who are with us online, we're really glad that you're joining us at such an important time when there is an opportunity for real progress on hepatitis C elimination in the United States. As the director of the Duke-Margolis Center for Health Policy, I want to describe how we bring together a range of perspectives to do policy analysis relevant to particular policy issues. And we're excited today to be able to present to you a strategic framework outlining what we have seen to be, from our collaborative approach, a set of core areas for improvement across the hepatitis C care cascade, across the whole spectrum of steps that can help support the goal of hepatitis C elimination. And this report is coming out at a time in the context of a major new initiative from the Biden administration with the bold goal of hepatitis C elimination through this important new federal 5-year program. We've circulated an agenda that can serve as a resource for you throughout the meeting. I'm also very pleased to announce that this accompanying report I just described was published today, and we look forward to further comments and discussions of that report at this meeting and beyond. So we've got a lot to discuss. Just want to start out with a few logistical items before we get going. Just a reminder that the Duke-Margolis Center for Health Policy, as part of Duke University, follows our tradition and policies of academic independence. On behalf of our faculty, scholars, and collaborators, neither Duke nor the Margolis Center take partisan positions, but individual members here and all of our collaborators, of course, free to speak their opinions on important issues. I also want to disclose that I'm an independent director of the boards of Cigna, Alignment Healthcare, Johnson & Johnson, and Prognomic, and also serve as an advisor for Arsenal Capital, Blackstone Life Sciences, and MITRE. Finally, a special thanks for support for this workshop and related activities made possible through Arnold Ventures, LLC. But again, the views expressed in the materials and our publications and by participants don't necessarily reflect the views of Arnold Ventures or any other particular perspective. And then a last introductory comment: we want these discussions to be responsive to topics that you feel like are important to bring up for this important and timely topic. So whether you're here in person and can get this Slido off the screens, or joining us online where you can hopefully access it as well, please use this Slido QR code to submit questions, comments, which we will try to incorporate in our panel discussions over the course of the afternoon. And again, you can use, for those of you who are in person, you can also use microphones that we'll have set up around the room for questions during the panel session. Before we hear from any of our panelists, just to get this process going, I want to provide a brief overview of the state of hepatitis C. I know many of you are deeply engaged in these issues and know all this already, for our broad audience, and also highlight and introduce the Biden administration's proposal to eliminate hepatitis C and how our recently released report fits into this context. So again, as many of you know, hepatitis C is an acute viral liver infection that can become chronic and lead to serious and costly long-term complications, with the disease progressing often without people noticing it. Multiple curative therapies called direct-acting antivirals have been available since 2013, but the number of hepatitis cases has not declined at the rate that many had hoped and expected would happen after those curative treatments were introduced. In fact, hepatitis C incidence rates have increased since 2014, and hepatitis C remains a major public health threat, with over 2 million adults currently infected in the United States. These adults are disproportionately coming from populations that are underserved by traditional healthcare systems. Individuals who are at greatest risk of contracting hepatitis C often suffer from many other health conditions, including substance use disorder, behavioral health conditions, HIV, among others. Persons who are Black, American Indian, Alaska Natives have disproportionately higher mortality rates from hepatitis C than white populations. Newly reported chronic cases were also high for those living in rural areas. Although a slow progressing disease, when untreated, it results in hepatocellular carcinoma, in many cases cirrhosis, liver failure, liver transplantation, and that all not only contributes to significant population health burdens, disproportionately affecting underserved populations, but also higher healthcare costs. Medicare data from 2012 showed healthcare costs between $10,500, $46,000 annually for people depending on their degree of disease severity. So treating early, intervening, is very important both for health and for avoidable healthcare costs. While many people with hepatitis C, most, have health insurance, particularly through Medicare or Medicaid, many populations disproportionately impacted are underserved by the nation's existing healthcare infrastructure or uninsured and don't have access to hepatitis C treatment or the care cascade to use these curative treatments effectively. For example, there are often high out-of-pocket costs associated with hep C treatments, even in cases where and also there may be additional restrictions on access to treatment, even for people who are insured, sobriety requirements, prior authorization restrictions, significant out-of-pocket costs, and then finally, people who are uninsured also may have additional access barriers to diagnostic care and treatment as well. So perhaps not surprisingly, given all of these challenges, even with the availability of curative treatments, and even though the cost of those treatments has declined over time, as those treatments have gotten even better, the associated costs of treatment and the use of treatments has declined as well. So multiple treatment options are now available. Starting costs around $84,000 back in 2014 has come down substantially, maybe 20% of that number or less. But still, usage has gone down, not up, with many states in their Medicaid programs still requiring prior authorization, and many commercial as well as Medicare insurance, often requiring significant out-of-pocket costs as well. So this shows a need for a more comprehensive and streamlined approach to drug coverage, but going along with it, as we'll talk about, a more streamlined and comprehensive approach to access to diagnostic treatments and care, the whole care cascade, to use those technologies effectively. There are multiple barriers in this care cascade. First, lack of infrastructure and capacity to scale effective models in primary care services, to integrate into primary care. That includes limited disease detection infrastructure across stakeholders, despite best efforts of stretched public health organizations and increased availability of diagnostic testing in commercial labs and healthcare organizations. There are also barriers and gaps within the care cascade itself, including what's often a two-step diagnostic process. That requires multiple visits just to get going on treatment, and then many primary care providers don't feel comfortable, don't feel like they have the capacity to oversee the use of the DAAs because they don't have integrated specialty care support. And then finally, challenges, as we've talked about, around drug costs and pricing under the fee-for-service models for these drugs that are still very common in insurance plans. So that's barriers at every stage of the care pathway, and as a result, patients lose the opportunity to move forward in completing this pathway, as well as getting into preventive care, longitudinal primary care supports to stay uninfected along the way for the longer term. So that's why there's been so much interest in a national approach to hepatitis C elimination. I want to highlight, I'm very pleased to have Francis Collins with us today, on the Biden administration's 2023 proposal to get to hepatitis C elimination through a 5-year national initiative that includes accelerating the availability of these one-step point-of-care diagnostic tests to make diagnosis simpler and more broadly available, broadening access to the DAAs, to the curative treatments through a national subscription purchasing model, to increase access and Medicaid for the uninsured and for some other federally insured beneficiaries, and then a comprehensive public health approach to improve access to hepatitis C screening and treatment. Our report complements and builds on this push for new national spending and a real attention to getting to an elimination strategy for hepatitis C. In collaboration with stakeholders and experts described in the report, the Duke-Margolis Center developed a strategic framework and implementation pathway to complement this proposed National Hepatitis C Elimination Program. And throughout this meeting, we'll talk about implementation pathways for these policy recommendations, how to augment and complement some of the ideas in the national strategy that are critical for getting to momentum and enough national support and resources to implement this program effectively. This implementation pathway falls into 5 strategic categories: diagnostic development and availability, disease detection and monitoring, population-based DAA procurement, awareness and education for the affected public as well as healthcare providers, and very importantly, care cascade integration into primary and community practice, a healthcare public health collaborative approach to not only making a real push on hepatitis C elimination now, but building it into our healthcare and public health systems much more effectively across the country. To sustain this comprehensive approach to hepatitis C elimination, significant upfront funding is essential, especially for uninsured patients. But this funding can also leverage ongoing federal and state initiatives to build the hepatitis C care cascade that I've just described and to support better integration among public health and healthcare organizations to identify and address opportunities to reduce hepatitis C incidence, prevalence, and recurrence. New hepatitis C initiatives can leverage not only recent biomedical innovations, but also existing authorities, initiatives at the state and federal level, and aligning these reforms can help increase the impact so the additional funding goes as far as possible to support sustainable infrastructures and enabling ongoing, built-in, better disease dissection, better capacity for delivery of treatment through primary care settings, and better sustainable financing behind all of these efforts. Healthcare payment reforms to strengthen the primary and community-based care, payment reforms to support diagnosing and treating patients in community settings, public health and healthcare data collaborations to target and improve interventions, community-based initiatives to address social barriers to care. All of these are steps underway across our federal government and in many states around the country that are helping us learn how to not only potentially address hepatitis C, but other ongoing infectious disease and public health threats. A combined approach to enable this new funding to collaborate with these existing and ongoing initiatives can help advance the hepatitis C diagnosis, treatment, and prevention efforts that we all want to see to have a lasting impact on the nation's public health. As I've mentioned, federal spending is important in all of this. Upfront federal spending is critical to enable all components of hepatitis C elimination strategy, particularly for uninsured patients. A population-based procurement strategy will result in lower net prices per drug, but it also means increased volume of those drugs from treating more patients. Upfront funding is also needed to accelerate the implementation of these reliable hepatitis C care cascades in primary and community practices. And important to note, and hopefully we'll talk about this with Dr. Collins, these initial costs could potentially be offset through lower Medicare, Medicaid, and other federal costs for treating hepatitis C complications like liver transplants and cancer, and by strengthening our nation's primary care capabilities more broadly. So with that framing, here's our agenda for today. We're going to be hearing reflections from a range of speakers who are involved in ongoing activities and have been studying these issues related to hepatitis C elimination in a wide variety of settings. all focusing on issues like how do we improve testing, how do we improve treatment, how do we improve supportive activities, and community awareness and engagement. We're going to start with an overview of some key background information and some perspectives on the hepatitis C challenges facing the United States. We're then going to hear, since I've given that kind of framing now, we're then going to hear from a patient advocate who's been very involved in these issues, Jennifer Sharp of Stop Harm on Tulsa Streets, co-director. Then we're going to have a fireside chat. As I said, very pleased that Francis Collins is taking time out of a busy legislative schedule, I think, Francis, to be here today. And then our next session will cover the framework components of an implementation pathway for hepatitis C elimination. In our session after that, session 3, we'll cover some of the key issues at the state level, some of the state programs that are in place and potentially could grow or be strengthened to support elimination. Then we're going to hear from Senator Van Hollen at a break that he's got in his busy schedule today about his perspective. He's been involved in leading some of these legislative efforts. Our next session after a break will provide an overview of some of the federal policy supports underway, and again, that could be enhanced to be part of a comprehensive, sustainable national program. So a lot to cover today, and I can't think of a better place to start than from someone who has been living on the front lines of the challenges of the hepatitis C infections and complications, particularly affecting vulnerable and underserved communities. I can't think of anyone better than Jennifer Sharp to kick off our discussions. Jennifer is a hepatitis C survivor, a patient advocate, co-director, as I mentioned, for syringe exchange program, the Tulsa Stop Harm on Tulsa Streets. So Jennifer, thanks very much for being with us today to share your perspectives and help kick off this discussion.
Thank you for having me. I'm really excited to have this chance to talk to everybody. Yes, I am a co-director at, our acronym is long, we go by SHOTS here in Tulsa. But yeah, we're a syringe service program. We're all Hep C survivors, like our directorship is, we're all Hep C survivors. All former injection drug users, and have just found ourselves in this space of being drug user human rights activists. I personally was diagnosed with hepatitis C in 2004, following the birth of my son. I was tested at my methadone clinic. I never was told through my late prenatal care that I had Hep C. I imagine there were lots of fish to fry at that point in my life. But I found out shortly after. It wasn't my methadone clinic that did the testing, though. It was a small CBO that I had known about and my friends had known about. They gave away condoms and did free HIV testing. So I knew them, trusted them. And they are who provided me with my result. And in that early time, I just remember having a lot of conversations with my healthcare providers. My first and only, I feel like the methadone clinic was one of those spaces that gave me a lot of support in that area. So while my methadone clinic didn't test me or provide me with a result, I got counsel from the clinicians there, and was just kind of guided based on my genotype. I was genotyped because I had Medicaid. I was prenatal or postpartum and still had some health care, and was just kind of encouraged, given my age and my health, to wait to get treated. At the time, interferon and ribavirin was the treatment available. And so I just kind of waited and monitored myself as I was able. That all depended on my access to health insurance at the time, which was spotty. I had moments where I had Medicaid and moments where I didn't. But when I did, I would get my viral load and just kind of try to keep tabs on what was going on, which was really scary. I found myself in the position a lot of the time to kind of share in educating my clinicians with what was going on with me. I think it feels silly now because we're in this whole crisis these days. But when I first got into care at the methadone clinic, I think I was considered kind of young to have that infection by the staff. And that's just kind of how I felt. And I know that has to have changed because I was in that treatment for so long and have met so many other people just like me. So, but I was encouraged, like I said, to just sort of wait for treatments that I think my clinicians were aware were coming around the corner. And it wasn't until 2019 that I was finally treated. And that was because my co-director started going to decided to get treatment. And I think that I highlight that because I feel like having a friend who was going through the same thing really made it feel accessible. It helped me to kind of stay accountable to the process, and let me know kind of what's coming down the pipe as far as treatment. It was all so much easier than I thought it would be. My son's dad went through the interferon and ribavirin, so I have that to compare it to. And I don't know, I'm so grateful for that, having had that opportunity to go through something so, kind of scary with a friend, and it actually not be scary at all, and fairly straightforward. And my clinicians were wonderful, and I felt informed, and it felt completely different than when I started out on that road. And so anyway, now I find myself at the SSP. It was through my work at the SSP that I got myself into treatment. But we partner now with that CBO that gave me my result. And they come with us and do hepatitis C, HIV, and syphilis testing for free for our syringe service participants. And yeah, I sure didn't expect to be doing work in Hep C, but it makes sense. My dad, it's worth noting, like my dad passed away as a result of hepatitis C infection, and completely unrelated, to my experience. But my work has just become to try to get people that connection to treatment. I feel like personally, I know how easy it is to slip out of care, to slip out of that continuum of care, to initiate, and then it to just feel too hard or confusing, or I don't know, there's the phenomenon of not really knowing what you're going to find out. So maybe you just don't want to know. And that if I felt like the less I had to think about, the less cognitive strain in the whole process, that I was able to just go do it. And then I was done and I was treated. And now I can share that with other people. So yeah, I'm really grateful to be here, and to talk about ways that we can work together to eliminate Hep C. And yeah, I would like to see access points for services like the ones we provide rooted in healthcare systems. It feels weird to say that sometimes. It shouldn't, but yeah, it's like the services that we offer, the referrals that we're able to make, they all add up, and they get people treated. So I'm really grateful to have this opportunity.
Thank you so much for joining us, Jennifer. We really appreciate it. Yeah. not only for sharing your own personal experiences and perspectives. I know this whole process has not been easy for you, but for all your contributions back, now working with those same community organizations that helped you and trying to get, like you said, this integrated, more built-in approach so that diagnosis, treatment, and preventive and support services can all be built around people by bringing together the community services, the public health, and the healthcare. Really appreciate your kicking us off on the right note. And now I'd like to turn to Francis Collins. This is an unprecedented time for supporting moving forward a comprehensive and coordinated approach to eliminating hepatitis C. And Francis has been spending a lot of time on that. I know how to do your introduction. Physician geneticist, Human Genome Project, NIH director for a really long and remarkable tenure, Office of Science and Technology policy director, now a distinguished scientist, distinguished investigator at NIH. All of that public service has earned him the Medal of Freedom, beyond, and other notable accolades. I should also say he's one of the most talented musicians I've ever gotten to know personally. But Francis could be spending his time on a lot of things. What he's chosen is really taking on this issue of doing something about this fragmented and incomplete approach to elimination of hepatitis C. So thank you for being here to talk about that with us today. So please have a seat.
So I can actually see you.
Yes, good idea for the fireside, not the panel. So the administration's proposal framework came out earlier this spring. I know from our, fitting into your busy schedule, we've been in touch about the ongoing work that you're doing with bipartisan members of Congress to turn that into a legislative approach. Can you tell us about where we are with that now? What should people know?
I would love to, and it's great to be part of this meeting. And thank you, Mark and Bina, for setting this up. And it's great to look around this room and see a lot of people who've been working pretty hard on this. And we're not done, but we are on, I think, a pretty good place to say we have momentum. I also want to give a shout out to my small but mighty team that's been working with me, because the White House has asked us to lead this effort. And that includes Dr. Rachel Florence, who's here, Dr. Isha Irvin, who will be talking in a panel in a bit, and Dr. Josh Sharfstein, who's back there in the corner. And having their assistance to think through this 5-year plan has been enormously helpful to me. I think where we are right now, it's fair to say, I think we have a plan over 5 years that is very detailed, very implementable, very much a plan that all of the parties that would need to play critical roles have been deeply engaged in the design and are ready to do this. If we can simply find the resources and get this launched, and my hope would be to get it launched in the next few months, because I think that's entirely possible. It is a 5-year plan, as you said. It has 3 components, as you said and showed in that slide. First of all, to make the testing paradigm much more amenable to the kind of test and treat model that you would like to have, instead of the prolonged process where we lose people right now as they basically wonder, why do I have to come back for the 3rd time for something that really should have been done in one visit? We're making real progress there with a point of care test that would give an answer about viral RNA in an hour, and then allow you to really do a test and treat. So, okay, it's positive, here's your bottle of pills. One visit, that ought to be the paradigm, and I think we can achieve that by getting approval by the FDA of such a point of care RNA test, which is in use in Australia and in the UK and a few other places, but has not yet been approved in the US. We think with the use of what is a very important partnership between FDA and NIH that was developed for COVID, this kind of clinical trial of the test, to be sure it has appropriate sensitivity and specificity, can be accomplished by the middle of next year. So I think we're on a pretty good path to have that as an opportunity by June. Secondly, we have to come up with a way to reduce the costs, because even at $24,000 a patient, which is better than $84,000, it makes it really hard to figure out how to afford this. For Medicaid, where many states, as you point out, haven't really got the resources, so they put up various barriers. And certainly for critical populations, the uninsured, the prison and jail system, Native Americans, where we know there's also a high risk. Those dollar figures have made it really hard for a way to be identified to get the cure to the people who need it. So the proposal here is this subscription model, as you mentioned, which was successfully carried out in Louisiana in a very creative pilot project, and much credit for those who designed that, including Rebecca Gee, who had a big part in that design, and Senator Cassidy, who, as the senator from Louisiana, was a big supporter of the opportunity there. The idea here is to ask the companies who currently have FDA-approved simple oral agents, 1 pill a day for 8 to 12 weeks. I'm glad to hear Jennifer say it was actually pretty easy because the side effects are quite limited. And the success rate is 95 to 98%. How often do we have a treatment that good, Mark? I mean, not really, especially for a virus, and yet here we are. So how do we do that? We ask the companies basically to look at the possibility of a subscription model where a lump sum is offered, in return for which, if that's agreed to, the companies make the oral agent free to the following 4 populations: Medicaid patients, the uninsured, people in the prison and jail system, and those taken care of right now by Indian Health Service, all places where currently the treatment, the cure, is not getting there very effectively. By the way, that captures most people who are involved in opioid treatment programs, which we know also can have as much as 40% positives for Hep C. So we're really trying to go where we think the greatest need is and where it's not being met right now. The third part, of course, is then to provide the kind of support for healthcare delivery that's going to be necessary. And you mentioned, yes, there are programs, and CDC is involved in this in a big way. So in terms of other kinds of healthcare support systems through HRSA and the community health centers, but they are not anywhere near where they need to be to take on what we think will be a significant volume of greater need, with 2.4 million people out there currently infected. We've actually done a bit of a survey of what currently exists in terms of federal funding. And while there is some assistance there, it is way, way inadequate for what would be necessary if we're going to make this a successful 5-year program. So a significant part of the proposed legislation needs to include that support for healthcare delivery. So those are the 3 parts. Where it is in terms of the actuality of it coming to pass, first of all, the administration is squarely and enthusiastically behind this. It was announced back in March as a Biden-Harris administration priority. Rachel Florence and I met with the president in person a couple of months ago and got a very strong endorsement of what we're trying to do, and basically go out there and get it done, Francis. I'm counting on you. And I'm totally willing to embrace that with enthusiasm. As you can tell, I'm a little obsessed about this. And then in terms of Congress, there has been a lot of effort to try to bring this forward as something that Congress would want to support. And shout out to 2 members of the Senate, one of whom is going to speak later. Certainly Bill Cassidy, as a liver doctor, has been very much in the forefront of trying to figure out how to make this happen, just as he had a role in Louisiana. Let's do it for the whole country. And the other, Chris Van Hollen of Maryland, who has also embraced this as a personal priority. Both of them have had staff efforts that are very engaged in trying to turn this plan into legislation. The goal is to have a bipartisan legislative introduction in the not too distant future, and the details are being worked on right there. Oh, hello.
Sorry, technical issue
Okay.
there. Please continue.
We know a fair amount about how this is all being put together and are quite pleased with the way that the legislative plan has taken shape. Meanwhile, I have personally by now talked to a couple dozen members of Congress, about half in the Senate, half in the House, and I've yet to encounter anybody who says, oh no, this isn't worth doing it. Everybody, when they sees this, sees like, wow, this sounds like one of the kinds of things our country should do. Of course, the question they ask is, how much is this going to cost? And that's a very important question in the current time where we're all worried about deficits. But in this particular instance, the calculations of the money saved, which you already referred to, are pretty breathtaking in terms of what can happen if you find now and cure these people who have this virus incubating in their liver and who, without that intervention, are headed for liver failure, liver cirrhosis, the need for transplant, liver cancer. A very detailed analysis of the economics was done by Jag Chatwal, an economist at Harvard, and that's in a preprint you can look up in NBER. And basically, he comes up with a calculation that in just 10 years, if we started now, we would save the federal government $13.3 billion in healthcare costs that wouldn't be necessary. And by 20 years, it goes up really steeply because of the long incubation period to about $44 billion. The actual cost of doing the 5-year program is going to be less than $13 billion. It will depend a bit on the negotiation with companies about what the subscription model looks like, but it'll be significantly less. The big question, of course, is what does CBO say? Because that's what Congress looks for. CBO is engaged in this right now. They have seen the Harvard analysis. They've talked to us. They seem very interested in learning what already has been done, thinking this through. But everybody I talk to says CBO will do it their way. And so we await, hopefully not too long from now, to find out what that number is. If that looks like it is cost saving, then I think we are on a pretty good path to actually see this come together as a bipartisan, bicameral support that could in fact be packaged as a mandatory funding stream if it's cost savings, and basically get attached to whatever budget is moving in January or February. And we could then potentially get this launched early next year. That is my dream, that's my hope, that's my determination. If I have any chance to help that happen, that's what I want to see happen. Because people are dying, 15,000 people every year dying of this disease needlessly now. I took the life of my brother-in-law in a terrible way. And I just can't see how any of us who both care about the economic side of this, we're wasting money right now, and the compassionate side, which is even more compelling. People are dying needlessly. How can we not do this?
Yeah, what a question to end on. Thank you for that comprehensive overview of where things stand and just how much effort has gone into this Biden administration proposal, all the interactions with Congress, all the interactions with outside experts and stakeholders. You know, I've had the privilege of working with you, at least off and on, for quite a while
20
now,
years,
back
I think.
before Medicare even had a drug benefit. And I got to say, Francis, I've never seen you as passionate about anything. So congratulations for that. And you mentioned that you see, as I was saying, there's sort of several obstacles that often stand in the way of major national initiatives getting through Congress. So one is perhaps vested interests, not being aligned behind this. And I'm not hearing anything along those lines. You talked about the three major components, making access to diagnostic testing simpler, one step. Sounds like that's on track and frankly not a very expensive component. Now there is a coverage issue there, speaking of Medicare, where as we'll talk about a little bit later, the U.S. Preventive Services Task Force has generally graded the hepatitis C screening as sort of B-level evidence. That's the test and the associated services, and that's not yet reflected in Medicare coverage and in many coverage programs.
It really should be, and I think CMS agrees that their national coverage determination for testing needs to be updated. It's still the 2014 or 2015 version, which doesn't talk about the current USPSTF or the CDC recommendations, which is everybody from 18 to 79 should be tested at least once, and pregnant women should be tested, and people at high risk should be tested every year. That's from CDC, that's from USPSTF, but it's not yet in the NCD from CMS, and I think they would like with a lot of staffing challenges, to figure out a way to do that upgrade, because it's not trivial. It takes a lot of steps.
It's something that a national initiative might provide some momentum to get addressed. You talked about as you were calling, subscription models. As you mentioned, there are some states that have adopted this in their Medicaid programs, but it hasn't been that widespread, even though it seems like at least some features of this model could work.
Yeah, I think some people are saying, well, just let the states take care of it. But think about how long that's going to take and how many states are really not in a very good position now to do that kind of negotiation. And furthermore, if you want to get the most efficient and most cost-effective deal, wouldn't you do better to negotiate this for the whole national market instead of 51 separate little pieces? So, I mean, God bless Louisiana and Washington State and Michigan and Missouri who've all started down this path. But if we wait for that to be the solution for the whole country, then I think we will have lost a really significant opportunity to just get it done.
And one thing we'll come back to today is, well, what are those obstacles? And again, can a national initiative like this one maybe get us to a new way of paying for certain drugs that, we could stay where we are with high fee-for-service prices and a lot of restrictions, or for these population-based treatments, just like we're doing in a lot of our healthcare payment systems, moving towards focusing on the population, linking to care delivery capabilities, and frankly, saving a lot of money on the downstream complications.
And importantly, I think the way this is planned for Hep C, this is going to be a win-win. The companies are not going to be expected to take a financial bath here at all. Basically, they're making very little money off of these 4 populations that we currently want to get the drugs to. So they will do fine. And unfortunately, in this instance also, the marginal cost of actually making the drugs is very low. These are easy small molecules to synthesize. So just as in Louisiana, where Gilead agreed to do this on a one-state basis, across the nation, companies are interested in this. I've certainly talked to the CEOs of both Gilead and AbbVie. They obviously want to know what the details are, but this is a model that I think in this instance at least, they could see would actually end up working out pretty well.
And then there's the care delivery capacity where, you mentioned Dr. Irwin's work, where there have been, some CDC and other supported initiatives that have shown this can be done. We're going to talk about that in just a few minutes in more detail. But they haven't really gotten scaled, the grant funding and maybe not enough sort of permanent foundation supports. As we just heard from Jennifer, she'd really like to see these programs more integrated. And again, seems like an opportunity for this initiative to make that shift happen. This is a priority for CMS to get to stronger advanced primary care out in the community, especially for vulnerable and underserved populations. Many states have shown that you can make progress.
Yep.
Or it seems like something that all sides support. It's just been slow going, right?
I think, and it's good that we've had now more than a year to really try to shape what this could look like. And this is not just my brainstorm about how to do this, because I would not really understand exactly all the details of what you'd have to do. But working closely with CDC, with John O'Merman and Carolyn Wester and Nate, who's here, we've really done a deep dive into what are the levers that they have the ability to pull. If they have resources, it's going to take resources. Let's be real clear about that.
I'm going to get back to that.
Working with HRSA for the community health centers, they've been very clear. This is what they need if they're going to actually begin to offer test and treat for the uninsured people who get their care. Working the Bureau of Prisons, they would love to be able. In the state and federal prisons and the jails are going to be a challenge, but we need to try for that too, because that's where in many instances you will find positivities as high as 40%, and here's your chance to get those folks tested and treated. But they need resources. Most prisons don't have the staff to do this. It's going to be very important, by the way. This point of care test is finger stick. You don't even have to have somebody who knows how to draw blood to be able to implement this test and treat in one visit. But all of that takes the kind of resources that currently don't exist. Indian Health Service also would really love to do more of this. That's the part of the legislation, that third part, that's going to be critical to be included. And I worry a little bit that people will say, oh, we have all these other programs, we can just take care of it. It won't work. It absolutely won't work. This is going to need a major new infusion of resources to be successful.
And it sounds like a lot then is hinging on the CBO analysis that you mentioned. I guess that's something that you're not ready to handicap at this point.
I wish I could.
I guess I guess it's maybe a category where you've outlined some of the work that's been done, showing the potential for substantial net savings, particularly for federal programs that are disproportionately funding care for people who don't get early testing and treatment. Is there a way to overcome the barriers to getting this upfront program implemented without a really favorable CBO score?
It'll be a lot harder. Yeah. I will say also HHS has their own actuarials that have looked at this. I can't divulge what their data actually showed, but it was very favorable and quite similar to the Harvard analysis in terms of what the cost savings would be. But CBO will have their own way of approaching this. They've seen the HHS analysis. If CBO comes back unexpectedly and somewhat devastatingly with a different analysis that says this is going to cost money above what will be saved, then we've got a tough challenge in front of us. As you would always do in that situation, you'd look at the program and try to figure out what are the things that we might be able to tweak here to try to get this back into at least a cost-neutral situation. I hope we don't have to do that, because I don't think there's any fat right now in the plan. So it would be cutting into the muscle and the bone. But if there was some way to still be able to do a lot of what's there, it is just too compelling to say, oh, I give up. I do think it's going to be a tough sell to the Congress to put something forward right now, certainly as a mandatory program if it's going to cost money, because the attitudes right now, particularly on the House side, are pretty negative about such things. So we will have to be very creative.
All right, and hopefully we won't have to have you back for that meeting, but really appreciate your spending time with us now. Maybe just one last question. Let's say this gets implemented. You take all these steps. You mentioned HRSA efforts around care, the shift in the way that drugs are procured, the greater availability of the of easier to use diagnostic tests. What does our healthcare and public health system look like 5 years from now? If you look at the countries that have been more successful, considerably more successful than we have, they have made, as you pointed out, these kinds of investments. But then they've still had some recurrences of cases, and they've also spent some effort embedding these capabilities within their public health, within their healthcare systems. At that point, now they've got a much lower case burden to worry about, so that's less costly and somewhat easier. But what does our healthcare and public health system look like?
Great question. First of all, we do need a vaccine for hepatitis C. I think everybody listening to this probably realizes you can get cured with the oral direct-acting antivirals, but you can get reinfected. Your risk is a little lower because you have some pre-existing immunity, but it's not totally protective. So the vaccine effort for Hep C needs to be rebooted, and that's part of the goal here with this package, although it's a very modest part of the enterprise. And maybe with mRNA vaccines where you could do a lot more multiplexing of the vaccine strategy, because that's been part of the problem because of the diversity of hepatitis C genomes. This could be finding its way to success. But I think you're also asking, how can this effort, if successful, do what Josh Sharfstein has been telling me is a good analogy, laying down the tracks for other health interventions in underserved populations that currently we don't do very well by. I would sure want to take every advantage to see how to do that. And if we have the kind of framework, the building up of health delivery capacity, the sort of mindset of moving ever closer to point of care testing instead of the clunky way we do things, then why not have that also come into bearing on lots of other problems that we currently don't address very well in our healthcare system, especially for communities that are marginalized. So yeah, that would be very much an explicit part of the hope and dream, to take hepatitis C and eliminate it, but also build a system that's going to do a better job for all of the people that we are not taking care of very well right now.
Francis, you've made so much of a difference in so many public health issues throughout your career. I am so glad that you're focused on this one now.
Mark,
Thank you for being here.
Thank you very much. Thank you, everybody.
All right, really appreciate that enlightening and frank discussion with Francis Collins. We're now going to go to our first session, actually second session, session 2, on a framework for advancing hepatitis C elimination. And then we're going to have some panel discussion about that. So I'm going to ask our panelists to come up in just a few minutes, but I'm going to be brief in these slides since we've covered a lot of these issues already. For those of you in the room, this may be a little bit of a hard slide to read, but we have learned a lot, as has just been reviewed here, about successful hepatitis C programs, ones that overcome all of those barriers that we've identified, and that the Biden administration plan and our framework are designed to help support. That includes a streamlined care pathway with a co-location of services out in our community, like you heard about from Jennifer, one that enables a single visit test to treat approach, and one that is supported by access to needed specialist expertise as backup for primary care frontline providers. It includes care coordination with community health workers, peer navigators, those who can help individuals who've been hardly reached and who remain underserved by existing programs, whether they're insured through Medicaid or uninsured or in another kind of healthcare coverage programs. It includes additional supports to make this pathway easier, ideally enabled by better data flows between community level and public health data systems on tracking burden and activity around hepatitis C, and the healthcare organizations that are doing most of the lab tests, reporting in on labs and cases in a coordinated way, in a way that could be less burdensome with electronic standards and data interactions. And it includes patient and provider education to support awareness and use of these better care and comprehensive approach models. And of course, we've talked about more population-focused approaches to drug procurement. So addressing these barriers to care includes moving from our multi-step and fragmented screening and diagnostic process to a single visit pinprick, as Francis envisioned, or at least so-called reflex testing, where one visit can suffice to do the screening and confirmatory diagnosis before we get to broad availability of a single-step test. Limited and fragmented disease detection, moving to a more integrated infrastructure with public health, healthcare, working together through modernized data systems to identify community-level health risks and the effects of interventions on them. Addressing coverage restrictions and copays for DAA treatments through the population-based procurement models that we've talked about, and addressing the gaps in patient awareness, provider confidence, especially in the primary care settings, about being able to get and use effective test-to-treat models and an effective care cascade that also extends to preventive services and ongoing primary care relationships. And along with that, the provider capabilities in the community setting to deliver this integrated primary and community care. So the report describes a number of components that can fit into this. So we've talked about innovative diagnostic testing. We've talked some about disease detection and monitoring. I should note that CDC is undertaking a data modernization initiative now that includes some important new steps for aligning with electronic record, lab reporting, national standards that healthcare organizations are increasingly using to, again, reduce the burden and increase the secure interoperability of data sharing to coordinate, track how communities, the local level, are doing on addressing hepatitis C cases and addressing how well interventions are working to reduce the burden of those approaches. We've talked about population level DAA procurement, the goal of lowering that per person cost of treatment and coupling it with steps on the care delivery side to reach many more people. As Francis said, that may not mean a lot lower net payments to manufacturers, but it does mean a lot more people treated. Lower price per drug linked to capabilities to treat many more individuals. It seems like a much better pattern of care and much better approach to both drug procurement and care delivery for these population health threats. By the way, these procurement arrangements could also include a different way of thinking about diagnostics purchasing and use at the population level. And then awareness and education about the availability of improved testing models, support for primary care practices, community-based care practices from specialists to back up treatment delivery. We've seen from Project ECHO and many other e-consult initiatives and coverage changes that support those approaches that these models can work. Peer-led initiatives to connect patients. I heard from Jennifer how important those are. And again, something that can be supported through community health, community care collaboratives. And then finally, this care cascade integrated into primary and community care. That means it's a stretch for our current workforce, but with community health workers, with support for primary care providers, and a team-based approach supported by payments, either through a new initiative or built into healthcare programs, ways to get there. Okay, so that's a lot of what's in our very comprehensive report release today and that we've already talked about here. What I'd like to do now is introduce our speakers to discuss where we are in terms of a framework for advancing hepatitis C elimination and the steps, both through an immediate or urgent national initiative and through building on the programs that you're going to hear more about later this afternoon, how we can get there and stay there as effectively as possible. So for our panelists, please come on up for those of you who are with us today. And I'd like to introduce in particular Dr. Rena Conti, who's an assistant professor with expertise in markets, public policy, and law at the Questrom School of Business at Boston University. Rena, nice to see you virtually today. Dr. Rebecca Gee, who's the founder of and CEO of Nest Health, former secretary of the Louisiana Department of Health, and as Francis mentioned earlier, has been involved from the start in these innovative drug procurement and care reform models to improve access to hepatitis C treatment and promote hepatitis C elimination. And then joining us in person, John Ward, director of the Coalition for Global Hepatitis Elimination, which is a program of the Task Force for Global Health. And just I want to thank all three of these individuals for being extremely helpful in our work that we released today, as well as for their ongoing contributions in hepatitis C and other issues around using effective medical treatments to improve population health. So thank you all for joining us. And again, just a reminder for those of you who have questions or comments, please use that QR code to send them to us. It's the slide code for the event, code HEPC, to get questions to our panelists. So let me start with some opening comments from each of you, and maybe I'll start with the order in which I introduced people. Rena, you've worked a lot on this issue, but also many others related to innovative models, developing and using prescription drugs, and getting them used effectively in care. Opening thoughts from your perspective about the framework and how we can move forward?
Sure. Thank you so much, Mark and Bina and the team for putting this together. And I am so excited to be here. We are in the middle of a momentous change, and I really thank Dr. Collins and Florence and Risha and Josh Sarstein for their efforts to lead the federal program. I have also had the pleasure of working with Rebecca Gee and Josh Sarstein and Senator Cassidy and the state team on making the subscription model a reality in Louisiana. So I'm an economist by training, and so what I thought I would do is provide a little bit more information about what we think the market failure is here and how policy interventions can really align incentives to get people treated and to keep supporting the innovation engine to bring new types of cures to market. So while we spend a lot of time thinking about the private market bringing these drugs to market and diagnostic tests as well, really it's government that supports all of these private sector efforts all the way along the continuum, from identification, basic science, research, development, and ultimately to the utilization of these products and their reimbursement. Fundamentally, what the problem in this market is, and this market, as Mark suggested, is actually shared by others, is that we have time inconsistent preferences with government policy. Government wants the private sector to bring these type of transformative medicines and other types of medical technology to market. We want that, and we support that in all different ways. patents, making sure these products are safe and efficacious and are what they say they are, government reimbursement for products when they exist. And yet, for these particular products, when they've come to market, while the commercially insured individuals have received access to these therapies, it's actually the government insured individuals, and specifically those who are insured either in state plans that have to balance their budget every year, or as Dr. McClellan suggested, the incarcerated folks who also face very limited budgets for healthcare in general, but specifically for expensive drugs, that find really access to be denied. So the intention here is to right that market failure by intervening. Now, what we did, or what has been done in the state of Louisiana, and what is being proposed here in the national model, is that essentially we'll align incentives so that the innovators in this space will gain reimbursement access. That should actually make them better off. And as Dr. Collins suggested, essentially what we are doing is swapping the ability for these companies to charge a very high price, knowing that they're not going to get a lot of uptake in utilization. And we're essentially switching that. We're saying, oh, well, we'll give you a lower price, but we'll guarantee much higher utilization of these particular drugs. This should pull people to use these products and hopefully provide greater revenue for the manufacturers themselves. Same story on the diagnostic side. I have data on the Louisiana model, and we are currently analyzing outcomes now. What I can tell you from a preliminary look at the data is that we are seeing very significant uptake of these products, and that uptake appears to be throughout the state. So it's not just in centers of excellence. We're also seeing this throughout the state, even outside the cities, outside the major centers of excellence. That's super exciting. We believe that there might be some exciting knock-on effects for health and for wealth for populations treated, which include ability to keep on working and taking care of your family, but also changes to the availability of providers and also the availability of transplantation for livers and kidneys as well. Happy to talk more about that.
Great. Thanks very much for those opening comments, and we'd like to come back to some of these issues. I think I'm going to go next to John here with me in the room, and then to Rebecca for some opening comments. So John, I know you've really been working on this issue extensively, and while one thing I was hoping you could work into your comments about where we go from here, picking up on Rena's point, is that gosh, it's like easy to see in theory how it'd be nice to have a model where we paid less per pill but had way more uptake of those pills, all of that working together. We haven't generally gotten there in the United States. We're going to talk more with Rebecca and others in a minute. But you've been working a lot with what I think is a bright spot in the U.S., as we highlighted in our report. The Veterans Administration has kind of shown how this can be done. They've got a procurement model that's more population focused. Mm-hmm. They've coupled it with redesigning care teams, supporting it with longitudinal data on patients, identifying gaps, and by our estimate, had something like 80% of veterans with hepatitis C. You're getting care through the VA, treated and cured, which is phenomenally effective compared to this kind of fragmented fee-for-service, uncoordinated approach that seems to be the norm in the United States. So maybe you could work that into some of your comments too.
Well, you said it all in some sense, but I think I was at CDC for 13 years as director of division of hepatitis, so I got very experienced in working with many aspects of the program for surveillance and implementation of testing linkage to care, including many that are in the room today and perhaps online. And so it's great to get together again and continue this pursuit of hepatitis elimination in the United States. Meanwhile, I've moved over to the Task Force for Global Health, which manages a variety of global disease elimination initiatives to start this coalition. And I've got more aware of what's going on around the world. I realize that there's essential components of effective elimination programs. It begins with good data, begins with good policy development, it begins with political commitment, begins with community mobilization, tailoring interventions appropriate for that health system and community, a focus on health equity so that everybody benefits from that testing and treatment program, financing to sustain your program, and then good data all along the way so you can improve what you're doing. And we've had some remarkable successes around the world. Egypt screened 70 million people, treated 5 million, reduced their prevalence from 10% to 0.4%.
And they've made progress in other
And as long as
conditions as well.
they brought that together with diabetes screening, et cetera, so they could strengthen other aspects of the health system. Rwanda, low-income country, same components put in place, 4 million people screened, 54,000 people treated, again, reducing their prevalence from 4% to less than 0.4%. Australia, 65% reduction in prevalence. They're on track to reach elimination goals by 2030. And the list goes on. Japan, England, even a small country like Lithuania just decided that they incentivize their primary care clinician with €12 every time they ordered a hepatitis C test, they could get elimination done. In a year and a half, they've screened 62% of their population going through primary care. Now, all that to say, and I'm leading up to the VA, so I didn't forget your question, is that we're not amiss in these kind of good model programs. And you'll be hearing from one, Risha Irvins from Hopkins later on, and Aaron Aronson is here from Chicago, who can also comment. But I think the shining star that shows that hepatitis is fully eliminatable, and that's achievable, is the BA program, where they put all of this, they put all of these components together. They realized they had a major problem. They put together a program with a continued feedback loop for quality improvement, and they can tell us the exact numbers lately, but I think they've had over a 90% reduction in prevalence. And I think all of these programs, I'd like for maybe Rachel or Angela to come up, and maybe you can give us a little bit more of a flavor of the key aspects, or David.
And for any of you, whoever wants to speak, I think we have a mic we can you.
Or we can share my mic, whichever the case may be. But as they're getting mic'd up, what all of these successes have in common is a national commitment to elimination, a national commitment to put all of these, marshal all of these resources, have some specific goals, and work toward them, and have a real sense of accountability, beginning at the national level to put all this together and feel responsible, all the way down to the provider level where they're getting information as to how well they're doing, and if they're not doing as well as others, why not, and how can that be improved. So that data piece and accountability, I believe, is really, really important. The other aspect that while we focus on treatment costs, understandably, I think we also have to focus on that testing piece. No testing, no treatment. It's really hard to keep people focused on testing, and then that linkage to care piece, so that overall health system strengthening to help people remain in care, even though we have a short course of treatment, making sure they benefit from that status. We have a rich toolbox of those different strategies. That toolbox can only grow as we learn by doing once this program gets going, as we have communities of practice to share that information. But really want to start with these key lessons learned from our pilot programs and then build out from there to make this program a reality. I mean, no one should be dying of hepatitis C in the United States any longer, 8 years after you've had the first drugs in the history of medicine that can cure a viral infection. Made possible, by the way, by Nobel laureate work by 2 Americans. I mean, we made this possible. Let everybody in our country now benefit from those Nobel laureate worthy discoveries. Applaud Francis for his commitment. Applaud all of your commitment. Let's spread that commitment so we really get this program over the finish, the financing over the finish line. So we have a budget-based, patient-centered model that we're putting in place nationwide.
And speaking of patient-centered models, I'm not sure who wants to comment from the VA experience on this, but if you could briefly introduce yourself and add to the insights we've heard already from John and others.
So he's on camera.
Yep.
Dave, come on up so you're on camera. Yeah, this is your moment.
I don't want to crash the system. David Ross, but I do want to say the people who really did the work, two of them are here, Dr. Angela Park and Rachel Gonzalez, also from VA, and then about, I'd say, 2,000 to 3,000 providers. So I'll be brief. And Dr. McClellan, I don't think we ever had the chance to meet, but when you were at FDA, I had the privilege of serving under you.
And I saw you on the elevator on the way up, too.
Oh, that's right. Oh, my God. I'm so sorry.
Second. This is the third time.
I was going to say, is this the way? Here. Also, I want to just thank Dr. Collins for your leadership and your eloquent essay in the Times. And I just, in the interest of time, I just want to say, along with Professors Conte and Guy, I just also want to salute Ms. Sharp for her courage in sharing her story. And thank you. I think there's two things I want to say very quickly, just share lessons from the VA. And as of this moment, treated and cured over 95% of the veterans in care who have hepatitis C. Not me. It's not, I didn't do it. It's these two young women here. I'm sorry, I'm dating myself here. And all the providers. But it's both patient-centered and population health model. And I think one thought that occurred to me is, in our medical schools and residency, if we could introduce into the curriculum, maybe it's already being done, the concepts of population health in addition to patient-centered care. The other things I want to mention are non-MD providers. We had a majority of scripts for DAAs in VA have been written by clinical pharmacists, NPs, and PAs. The SVRs, sustained viral response rates, for patients treated by those providers are the same or gray higher than for specialists. Of course, there's some selection going on. Secondly, telehealth and telementoring. Mentioned Project Echo. Sanjeev Arora, who is a rock star, has showed some years ago that primary care providers can get equivalent results in VA using our modification or our implementation of Echo. Have shown that Echo reduces time to treatment by 75%. Dr. Grace Sue at Ann Arbor, looking at Echo and liver disease, has shown a survival advantage of 50%. That goes beyond Hep C. Two other things, and of course they're escaping me right now. Integrated care. And this is one of the reasons, the cost. I was talking to a ID colleague of mine, and he said, we cannot afford to treat Hep C in our offices. We'd go broke. And he's not saying the need isn't there. Of course it is. But having that kind of care takes a lot of effort. And I think I'm so excited to hear about the point of care testing. That will revolutionize things. And then, I'm like, what's the fourth? No, we're not going there yet. We will. But I just want to say, I think there's a paper in Annals of Internal Medicine from 2017. David Shulkin and Pam Belperio are the authors that talks about the principles. But I think data. That's really key. So thank you. I appreciate the opportunity, and thank you for your leadership in this, both of you.
Thanks so much, David, and the rest of the VA team. I really appreciate that added perspective. Okay, now, speaking of person-centered, family-centered care, Rebecca Gee, you've done a lot over your career, but I think it always comes back to this person-family centricity. You took some important steps in Louisiana to get to these population-focused approaches with the drug procurement, with these other steps to try to advance diagnosis and the test to treat pathways in Louisiana. Really appreciate your being with us to share your perspectives.
First of all, Mark, I'm one of your biggest fans. I have the pleasure of sitting on your board, and you are just a remarkable leader. Thank you for your incredible efforts to bring this panel together. And then, of course, Francis, my new BFF, Rachel and his whole team, just remarkable to see you putting your extraordinary capacities towards this critical and life-saving effort. And then finally, my dear friend Bill Cassidy, our senator from Louisiana, just someone who's helped. And then just to say, Josh, Rena, John Gruber, Alex Bu, and Pete Krogan were kind of, I called them the Avengers, the Hep C Avengers, because when we decided to tackle this issue, I'm an OBGYN, right? So I was not, I think what was fundamentally missing at the time that Louisiana pursued our efforts at a subscription model was a sense of urgency, right? You had a sense of urgency in the VA, but I cannot tell you how many people told me, oh, this isn't a problem, right? We have this fabulous blockbuster drug. It's not too expensive. Don't worry about it. The problem will solve itself. And the bottom line is the problem of hepatitis C does not solve itself. It requires, it did require a pricing structure that works for Louisiana. When we did our numbers, what we found was that the cost of providing this to everyone who should have it, which is everyone incarcerated, right? That was another thing that Louisiana focused on that other states did not have the same level of focus on, which was, if we're going to solve this issue, which is ideally with the resources we have in America, to eliminate this virus entirely. That should be our goal. We can't ignore incarcerated people who are very likely to have been exposed to this virus. And then Medicaid, right? We've got to focus on Medicaid. We simply couldn't afford it. That the cost of this drug at the time would have cost more than our entire state budget. And I was Secretary of Health, so I had half the state budget under me. But still, the budget for Hep C would have exceeded the K through 12 plus correctional budget. And I think we can all agree that that's not a fair trade-off, right? We can't say, well, look, we're not going to provide K through 12 to treat Hep C. And so through the efforts of our Avengers, I think many of who are here today, and a lot of asking of questions, we were able to come up with this new model. I think it's really important to continue this focus. What we see in Louisiana is really exciting. We can get this done nationally. There are many, many ways to achieve it. I'm very excited about the policy solution that Dr. Collins has put forward that has a lot of bipartisan support. And so I would just say, I think this is, there's so many issues in healthcare at Nest. I'm now the CEO of Nest, where we're providing healthcare at home to vulnerable families with children. And there's so many issues that are hard to solve. Hep C ought to be easy. This is an easy one as a nation. It's just an issue of focus and marshaling resources and bringing together these great ideas from the VA, from all of the wonderful academicians who have written and researched it, and the folks who help us get this work done in Louisiana, as well as many others. So let's just get the damn thing done. And with that, I will hand it back to you, Mark.
Okay, so appreciate the enthusiasm there too, as always, Rebecca, and thank you. Let me go back to Rena on this. So we've talked about and just highlighted again the opportunities around around population-based drug procurement models. There's subscription. There's sort of the approach that the U.S. took during the public health emergency of buying enough vaccines, therapeutics for the whole population. How do we build this into more routine approaches to care like the VA did? So, Rena, in your comments, you talked about as you said, the better equilibrium here is lower net price per drug, because the cost of producing these pills very low, but much higher volume. Is this a case where lowering the price is going to be enough? What else is needed to build out the steps that John and our colleagues from the VA described around data, around delivery capabilities for both diagnosis and primary care-based treatment, so that volume goes up because the capacity is there when the price comes down? A lot of the individuals who are still, unfortunately, untreated or undertreated may not have access to that kind of care, and may not even have awareness of their condition today. Rena, maybe I'll start with you.
Yeah, thank you so much for the comment. So lowering prices of these drugs is not enough. there must be accountability on all sides. And specifically, what was built into the Louisiana program was that there was incentives for the state to go out and screen and convert to treatment these people. The key here, as I think we've heard throughout the day already, is getting people identified as potentially eligible for treatment and then keeping them in the system connected to care to ensure that they do complete their 8 weeks of treatment. They do receive, or 8 to 12 weeks of treatment. They do receive all the other care that they might need as well. While they're in our system and identifiable and connected to care. So that is a very key component. The point of care testing innovation here is absolutely key. And I think we've heard over and over again, the existing testing is very high touch. It's very high labor costs. It requires significant commitment by the patient, which is difficult. It's difficult on our healthcare system. It's difficult for people with lives and other responsibilities. So being able to screen and convert to treatment people, it's been shown to be effective in other settings. I think it's going to be really effective here. One last thing, which is kind of what's the bigger context. I think the bigger context is unlike many drugs for which we are not so sure that what the benefits are in populations that are not in clinical trials. There's a significant amount of uncertainty about the benefit. Here, like this set of drugs and many other sets of drugs, it's a cure. There's no uncertainty about what this product does or how much benefit it provides to individual patients, but also because this is an infectious disease, their families, their communities, et cetera. So at this point in time, in these type of drugs, we should want to convert people to treatment because it improves their lives, it improves population health, and it improves the wealth of our country.
Yep, great, Rena. Agree with everything you said. In addition, we have to do a few things. One is that we cannot kid ourselves that we can do elimination if Americans don't have healthcare coverage, right? So the Louisiana model, as should any national approach, should rely on healthcare coverage. That just giving the ability to diagnose and treat someone depends on them having coverage. Medicaid expansion, which was a decision by Governor Edwards that I was responsible for enacting, is so critically important to us. It is one of the reasons likely that there are states that are really falling behind. And then second, that the price is not enough, right? That you've got to have what we had in Louisiana, and many, again, people participating today were involved. Risha Irwin, Rena, many others, to say, look, we're going to have a testing approach. And back to the point of care, I'm so grateful that Dr. Collins and his team have made so much progress there, because when we were trying to eliminate Hep C from the prisons, there was only one phlebotomist who took care of about 10,000 prisoners. As you can imagine, that's not enough. There's no way to get enough people tested. So being able to do point of care testing is critical. Having education, the Project ECHO work is so beautifully done, and something that we implemented here in terms of the idea of train the trainer, right? So you have the super hepatologists like Bill Cassidy, who can train others to be able to diagnose and treat individuals with hepatitis C. You need a public health approach where you're utilizing on the ground individuals who can find people with hepatitis C. We implemented syringe service programs, actually had our law enforcement folks help us to pass a law that syringe service was available, because of course you want to reduce the burden of the virus in the general population, especially for those who are using drugs. So all of those things are critically important and needed to be done in addition to the price. But I'll just say the price was important, right? Without the price, there's no way we could have gone out and said, we're going to look under every rock and treat every single person we can. And every incentive that we put into that program was to get someone treated. What we didn't want to do is say, oops, we treated 999 people, but now we're at number 1,000 and we can't afford it as we're not doing anyone a service. So this is really important, is that public health approach married with the pricing was so critically important for us and informed by the VA and many others. We actually had a convening in Louisiana where we invited folks. I think, Brina, you were there, Josh was there, from all over the country, and said, look, here's how we would do it. And we took those recommendations and implemented them. So I think the same kind of thing is what's being done now. Let's get all the minds together, such as those in this room, and make sure we don't make any mistakes, repeat any mistakes we made in the past.
Thanks, Rebecca. And I do want to. Sorry, if it's quick, we're getting tight on time, and I have a hard question for John.
It's quick, which is one of the things that we encountered in the Louisiana model, and I think it's important here, is that when various folks approached the companies and said, listen, we really think that there might be a win-win policy here, might you support it? I think there was an initial amount of skepticism that this was just really an initiative that was trying to shame the companies for pricing these products so high. And it took a lot of time and effort to assure that actually that is not what the intention of this was at all. The intention was to actually push forward a public health solution to this problem, among others, that would actually make everyone better off. Individuals, patients, the healthcare system, and of course the companies. And that's why rights and responsibilities alongside and really building trust is important here. But if we can do it here, we can do it in other places too.
Right. So on that positive note, this isn't that hard of a question, but I do want to ask you to take your international experience back here to the U.S. So what Rebecca Gee did in Louisiana was in significant part, not only, but in significant part through Medicaid, so public insurance program for many of the people who were affected by hepatitis C and not getting diagnosed and treated. We're going to turn in our next panels to Medicaid opportunities and undertakings. And as Francis said, there's been some progress, but maybe not as much as we'd like to see, despite, I would say, a lot of leadership at CMS and a lot of leadership across the states really putting these person-centered care models that ought to be able to do hepatitis C diagnosis and treatment right at the center. And then we're going to talk about Medicare. Then we're going to talk about some of the CDC and other federal programs as well. All of these are supporting private healthcare delivery organizations for the most part. So not VA, but nonprofit, fairly qualified health centers, maybe for-profit, independent, small practices, larger nonprofit or for-profit health systems, private health insurance plans in Medicaid, and increasingly in Medicare. How do you take those steps that you were describing, like the additional payments for diagnosing and treating patients, and bring them into support for our largely private healthcare delivery system, including for many of these underserved populations?
Yeah. Well, it's because it takes multiple stakeholders to achieve elimination. That's what is lessons learned around the world, and even in these pilot programs. It takes, industry has to be at the table, insurers, the health systems, professional associations, civil society has a key role. And I think what we need to ramp up a little bit, and maybe it is, and I just haven't been invited to, is some of those stakeholder meetings. I know when I was at as the division director, and we put forward the baby boomer testing recommendation. We had we brought together the insurance companies. We brought together how are you going to implement this? Commercial laboratories, how are you going to implement this? Professional associations, public health associations, et cetera, and really, created a team approach. And for example, quickly, we had, a major health information system company come to one of those meetings. 2 days later, he calls me back and goes, John, on the way to the airport, on the way home, I just put in the code to make it an automatic reflex reminder to test every baby boomer as they enter into their health system, and that will be in our next version that's going to be available. And he did that, free of charge and everything. So I think creating more of that sense of national commitment, this is really important. our national reputation is on the line. Let's all do this together. I think that's the other sort of secondary benefit of having that national program, is everybody buying in and seeing what their role is, and I look forward to creating that kind of opportunities.
All right, a real public-private
Mark, can I-
partnership. It's
can
got to
I
be
add
super
really-
fast. You guys are great, but
Very
we are
quickly,
out of
I
time.
think exactly what John was talking about is what is needed. Look, we've got to have a national program. And what Louisiana did is admirable, but obviously we're a nation of states. This virus does not know state boundaries, and we must eliminate it as a nation. And so the plan that's been put forward by the Biden administration that includes a public health approach that was mirrored and looks very much like the Louisiana approach, along with the pricing, we think is critically important and will save many, many lives. So we're so excited to see that and hope that it advances, along with, of course, Mark, the work that you, the team, and we have done at Duke-Margolis. So thank you
Great.
for having us
Thank you.
today.
Thanks to all of you on the panel, and this is a great lead in to what we're going to talk about next, is how the public, private sectors can work together, John, exactly as you said, to get to a national elimination strategy that's effectively implemented. Thank you all very much.
Thanks, Mark. Thank you. Great.
All right, and for this next session, which we're going to switch our focus to states, and would very much like to emphasize federal supports for state-based initiatives working with their private healthcare providers and their state and local public healthcare systems. Very pleased to introduce Dr. Marianne Hamilton-Lopez. Thanks, Marianne.
Give Mark an opportunity to catch his breath for a second. So good afternoon, I'm Marianne Hamilton-Lopez. I'm a Senior Research Director at Duke-Margolis, and I oversee our biomedical innovation portfolio. And during this session, as mentioned, we're going to focus on state and local level activities that will help advance hepatitis C elimination. Give me 1 second as I figure out the clicker. All right. So we've heard a little bit about this so far, but Medicaid does play a significant role in expanding coverage and incentivizing hepatitis C services. The framework components discussed in the previous session can be implemented through several levers, which include Medicaid state amendments, SPAs, 1115 demonstration waivers, and managed care contracts. These mechanisms can be leveraged in support of some of the key strategies for a hepatitis C elimination program for populations placed at risk, including portions of the uninsured and incarcerated, as we just heard. Federal guidance and template models will help Medicaid organizations integrate hepatitis C care cascades into primary care and community practice, increasing and extending the impact of new federal spending on a national elimination initiative, including drug and diagnostic procurement, care integration strategies, and disease detection. In the next slide, I'll cover these authorities in more detail and address some of the key strategies for a hepatitis C elimination program. So states submit state plan amendments to CMS in order to make changes to how their Medicaid program is administered. SPAs have mostly been used to shift the scope of services covered for a particular population, included processes for provider reimbursement and eligibility determination standards. SPAs are therefore an important mechanism for states to implement targeted reforms that support hepatitis C diagnosis and treatment for Medicaid beneficiaries. Drawing from many state examples, we have laid out several ways that SPAs can be used for these efforts. They can include population procurement agreements for DAAs, as we've just been discussing. They can also be used to expand the types of providers that are recognized as reimbursable providers for hepatitis C. Illinois, for example, has a SPA approved to allow pharmacists to provide services that are related to HIV, pre and post exposure. This supports implementation of non-traditional care delivery models, which can help mitigate barriers to care due to provider shortages. SPAs are also a mechanism to include new coverage and payment methodologies for hepatitis C diagnosis and treatment, including support service such as care coordination, telehealth specialist consultations, Several states, including Louisiana and Rhode Island, received approval to reimburse community health workers for a range of care coordination or case management services, helping patients adhere to treatment. In the last example, spas can extend reimbursement eligibility to non-traditional sites of care, such as mobile clinics and harm reduction sites. A New York spa allowed the states to allow reimbursement for specific harm reduction service to New York Medicaid beneficiaries who had used drugs who have used drugs have access to benefit as authorized syringe exchange programs. Section 1115 demonstration waivers. They are a way for states to waive state plan requirements and support broader changes compared to spas. Because they are a more substantial undertaking for states to negotiate with CMS, Section 1115 waivers are utilized as an approach to implement more systematic reforms in Medicaid, such as broader payment reforms intended to strengthen primary care. CMS guidance and federal financial support could encourage states to support hepatitis C elimination efforts in their Section 1115 waivers by implementing hepatitis C focused initiatives in managed care contracts, by expanding coverage for hepatitis C services for additional populations, including incarcerated populations, into Medicaid upon transition back into communities. For example, California was the first state to receive CMS approval for a waiver to extend select services to all Medicaid-eligible adults and youth in correctional facilities who meet certain health criteria 90 days prior to release and support with continuation of care after release. 1115 waivers can also implement hepatitis C-focused initiatives in managed care contracts and broader payment reforms intended to strengthen primary care. Within their Section 1115 waivers and associated plan amendments, states also have authorities through contracts with Medicaid managed care plans to incentivize hepatitis C services. States should consider using managed care contracts to support hepatitis C elimination by enhancing and aligning provider reimbursement through plan contract incentives to strengthen primary care, including increased diagnoses, treatment, and prevention for hepatitis C. For example, states can direct MCOs to implement value-based payment arrangements or performance initiatives to incorporate financial incentives linked to performance measures. MCOs then have flexibility in how they increase hepatitis C services to meet these performance improvement targets. Plans can provide patients with case management services, conduct provider and patient outreach, and leverage authorities such as in lieu of services and value-added services to direct reimbursement for social services that address health-related social needs. There's also an opportunity to utilize performance improvement projects to set hepatitis C quality improvement goals and to implement standard quality measures for hepatitis C care aligned with traditional fee-for-service Medicare. In addition to what we've just laid out with states, there are a number of additional supportive actions that can be taken to build capacity at the local level to improve the efficacy of Medicaid mechanisms, as well as further reach the activities under a national effort, including collaboration and coalition building to align regional stakeholders for a unified and community-driven approach, public awareness on risk factors for hepatitis C and treatment access, primary care provider training to an increased hepatitis C screening and treatments, technical assistance to build capacity at the site level to implement hepatitis C treatment programs, and a robust regional and state disease detection and monitoring to identify and respond to outbreaks, engage patients with active infections and care, and track progress towards elimination. The incarcerated population, as we've heard throughout today's comments, is one population that needs significant consideration. Given its high prevalence of hepatitis C and limited resources to health care, These activities can also be expanded to reach incarcerated persons to help with linkage to treatment following reentry, as well as increased access to providers trained in Hep C treatment, capacity building to implement non-traditional care models such as the mobile clinics or telehealth, and increased education to reduce transmission. Okay, so during this session, panelists are going to discuss administrative levers that states can use to expand access to hepatitis C among Medicaid-eligible populations, incarcerated and uninsured populations, as well as implementation considerations to build capacity at the regional level. I'm going to invite my panelists to join me, and I believe we have one online. Hi, Jude. All right, wonderful. Oh, thank you. So I am joined by Colleen Flanagan, who is the director of the Bureau of Hepatitis Healthcare and Epidemiology at New York State Department of Health. Dr. Risha Irvin, is she online?
No, I'm here.
We're good?
She's right there.
Right here even. That's amazing. Who is the associate professor at Johns Hopkins School of Medicine in the Division of Infectious Diseases, and Dr. Judy Zerzanthul, the chief medical officer at Washington State Health Authority, Washington State Healthcare Authority. So I'm going to come sit by you guys. All right. I want to start with Colleen. If we could hear some opening remarks.
Hi, yeah, thanks so much for having me today at this really exciting meeting. I really like what I'm hearing, and you know, we all know specifically for this particular session how important it is to sustain these programs, and sustainability really means billing and reimbursement. And so in New York, we've really been trying to co-locate hepatitis C treatment in non-traditional healthcare settings. And so I know that was mentioned in the remarks by Marianne. And I think that, you know, a couple of things, you know, you mentioned a SPA. And so New York State did do a harm reduction SPA many years ago. It took about 4 years to get that SPA approved. And what happened was that it was very narrow in terms of the services that were able to be reimbursed, billed for and reimbursed. You know, there was also a narrow group of individuals at the syringe exchange programs that actually could bill for the services. And so New York State, probably about 2 years ago, decided to open up that SPA again and re-look at the services and who can bill for those services, as well as you know, understanding why the first SPA and the first harm reduction benefit was not something that there was this great uptake. And I think one of the major issues was that even though a service may be billable, these types of programs don't have the resources to do the billing. And so you might have this benefit. It may sound great, but the syringe exchange programs didn't have the resources to implement billing. We know how many resources it takes to have a very robust billing program. And so we are looking at that SPA again, looking at how we can do better this time around, actually considering a contingency management model for reimbursement, where the program would actually get a portion of the reimbursement, and the individual, because we know incentivizing services at certain points across the care continuum is super important. And so the contingency management benefit would allow that to happen. So I think as we think about sort of sustainability, and we think about utilizing Medicaid and billing and reimbursing for services, we need to take into account whether or not these programs where these services are happening have the resources to implement, to conduct billing. So that's one example that I wanted to mention about SPAs. So they're a great idea. They do take time, but they have to be well thought out.
Wonderful. Thank you so much. Risha?
Yeah.
Just want to say I'm really excited to be here today as we talk about advancing hepatitis C elimination. And really great to see so many people that I know have been dedicated to this over the last decade. I think, from my perspective, comes from a few places. One, being a Hep C tester and counselor on the ground and seeing all the barriers that my clients and patients faced with just being linked to care and not having the public health implementation support to get to care. Running a training program where we train providers to treat hepatitis C infection and really trying to expand that to both primary care, substance use providers, pharmacists, HIV providers, also working in corrections, and then getting to be a part of the national team. I think what is very evident to me, and I think those in the room, that the national plan is really the catalyst to get us to where we need to go, because we all have been doing this work, but there's been a piece missing. And so having that national framework can really get us there. And I think thinking about how states can then work on it, being synergistically in line with kind of those national efforts and really helping us maximize the components of the program, I think is really important. I think in the presentation it was noted some ways, and for instance, that we might see some movement in kind of Medicaid, and I'll touch on a few things. But I also wanted to say that as we are focused on hepatitis C today, it's not just about hepatitis C, but bringing people into care. And do want to mention that one of the other things that I think we're very excited about on the national team is also thinking about hepatitis B. And bringing people in, getting them tested, but also having funding for rapid diagnostics for hepatitis B as well, which will be really important. When we think about states, I wanted to touch on a few things, and I'll say justice-involved populations are really near and dear to my heart. And when we think about justice-involved populations, we're talking about pretrial detention, people in prisons, both state and federal, people in jails, and then individuals that are being released as well and coming back into society in that kind of transition period. I think all of us in this room know about the increased prevalence that we see in prisons and jails, but the question is, what do we do about it, and how can states facilitate the work that needs to be done there? I've spent a good bit of time talking to individuals in corrections, and I'll say that there is a lot of excitement about testing and treating hepatitis C. The issues have been one around direct-acting antivirals and cost, and that's come up today, but that would be taken care of by the national subscription model. But the other issue is the public health implementation infrastructure within prisons and jails and not having that. So wanted to highlight, again, Louisiana and kind of what they did in their model was that it was a partnership between the public health department and corrections. And I think that's really important. And another thing that states can do is forming these partnerships. And so it was essentially the health department sending in a nurse and a phlebotomist to each state correctional facility to get the population tested who was already there. You can add entry and exit testing, but we've got to be able to test the populations who are already currently incarcerated. And so I think that's a way to think about another thing that states can do. I'm also very interested in this transition period when people come out of prisons and jails and how we cover them. And so I think the great thing about, again, the national plan is that there's coverage for the uninsured. But again, this idea of kind of demonstration waivers and potentially being covered by Medicaid as well is, I think, another way to kind of think about that. I think the other thing as we think about kind of Medicaid programs and some of these other models and expanding kind of who can treat, and it's already been highlighted, the great work done by the VA in terms of pharmacists. And so I think, again, we have to make sure that pharmacists across the country are able to actually treat and lead kind of treatment. I think it's going to be really important in some areas in terms of rural healthcare or other places just where people are not having touch points with the healthcare system. Telehealth models and making sure there's reimbursement. Again, we know that these models exist. There's a lot of data, but they haven't spread to the level that we need. And a lot of that has to do with how we incentivize the system and making sure that they're incentivized. We have programs in Maryland where the academic health centers have partnered with our local health departments across the state to be the treatment provider in areas where they don't have much of healthcare infrastructure for hepatitis C. And so I think, again, doing things like that. When we look at substance use treatment centers, again, it comes down to how you reimburse people for the care that they're giving. We know we need to be there. So again, how do we get there and get that work done? And then the final thing I wanted to touch on is just data. And again, this has been underscored a couple times now. But if you look across the country, most of our states have no idea how many people actually have hepatitis C. That's a problem. So another thing our states can do in terms of making sure all hepatitis C test results, positive and negative, are reportable, but that they have teams that can actually act on that data. So epidemiologists who can monitor that data, look for outbreaks, and then act on that. And so I think those are some of the things that, as we think about what states can do to reinforce national efforts, those are some of the things we can start with.
Excellent. Thank you. Judy.
Hello, everybody. I am from Washington State, and we have been working on hepatitis C for a long time. We had a lawsuit that ended up with a judge ordering us in July of 2016 that everyone with Hep C needed to be treated in Medicaid, and so we had a really big, treat a whole bunch of people when that happened. And then in 2018, Governor Inslee made a proclamation both to the Healthcare Authority, which covers Medicaid, public employees, and school employees, and our Department of Health, the public health agency, he directed us to eliminate hepatitis C by 2030. So since then, we have been solidly working on it, and I'd say making some progress. And so at the Healthcare Authority, our part of that executive order was to develop an innovative procurement, as is being talked about. And so we did an RFP that resulted in 2 contracts, one on the Medicaid side, which is the models that have been in the news. We have a guaranteed net unit price on the pills, and after a certain threshold, then it becomes very low penny pricing kind of thing. After we hit that threshold. We are currently in year 5 of that contract, and we have not hit the threshold yet. So that is some work to do, I think. And when we started, I think that threshold was sort of uncertain of how should we figure out how many people we can treat and what does that look like. And every year we've lowered it to try and make it something that's accessible, particularly during COVID. There was much fewer testing. There was a lot of people not seeking care. And this year so far, we're on track to hit it. So I'm very excited about that. We also partnered, AbbVie is the company that won our contract. On the Medicaid side, we partnered with them for outreach to populations, and they made a bus, which is so cool, I think. So they retrofitted this big RV, and they take it to community events, sometimes health fairs, different things. They take it to about 6 to 7 events per year, and they do testing at those sites. They do counseling. They connect people with care. And overall, they have about a 9% positivity rate at those events, but depending on the site, some of those sites have a 20 to 30% positivity rate of people that come in. And so those are the places you got to get to. The second contract was for the non-Medicaid side, so public employees, school employees, our labor and industries, which is workers' comp, corrections, our state hospital has another, it doesn't have that same innovative model because the rebating doesn't work that way. But a couple of different things that we put into place when we signed this contract is that we really, as has been mentioned here, we really broadened who could treat hepatitis C, including pharmacists under collaborative practice agreements. We eliminated the prior authorization on Mavyret. There's no sobriety requirement. There's no fibrosis requirement. There's no wait time. So you don't have to wait and see, do you have acute hepatitis C or are you going to develop chronic? You get the drug and we're going to treat you. And I think that has been pretty successful. So those are probably the successes. The places that I think we still need help and where I think a national plan will help, and this has also already been mentioned, but the rapid testing, I think that is the main part, especially in our bus outreach, that not only do you touch that person the first time, but then you got to go find them again to tell them their result. And so if there was, a test that was at the point of care that we could use, that would be a game changer. Second sort of opportunity, I'll call it, is that in Washington, we really treated already. We probably treated by 2018 all of the easy to reach populations. The populations that we are now struggling to find are the ones that don't seek medical care. They're not engaged with the system. Maybe they have addiction. We have to find places to go to them. And so we're working on embedding folks to both test and treat in syringe service programs, in opiate treatment programs, sort of go to where people are to treat them. But some barriers there are that the medications are still pretty expensive. And so a lot of pharmacies, a lot of folks don't want to stock them because they're wondering, how are we going to get paid for it, this cupboard of expensive medicines. In Washington, we have the 1115 waiver that you mentioned that California started with. So we were second in line for that, and we are working on how we use Medicaid dollars and Medicaid resources to treat folks in correctional facilities. I think that is going to be really huge and helpful. Up to now, the state budget has limited the availability of Hep C medications in corrections, and so I think this is really going to help with that. And then I think the last piece that is important to talk about is the stigma. We definitely have folks, including primary care people, who don't want to treat people with hepatitis C. They don't want them in their clinic, and that can be pretty challenging. And I think particularly Washington has a fair bit of rural areas. In rural areas, it's hard to, again, stock these medications in pharmacies and worry about their expiration date and worry whether someone's going to treat them. And so I think there's a fair bit of stigma and kind of myth busting that has to happen in that space, including, even if you don't have the stigma for people with addiction and opiate use disorder, primary care folks not always understanding how easy it is now to treat people and cure people. And I still talk to PCPs that are like, oh, it's just hard because I have to wait to go get them tested for their fibrosis score, and I have to do this, and I have to. I'm like, no, you don't have to do any of that. You just write them a script, and it's so easy now. And I think medical practice takes a while to change, and I think more education on that piece and empowering folks that no, this is really an easy thing you can do will be helpful. So I'll stop there. You can ask us questions.
I will. Thank you. Excellent comments from everyone. Before we do go to the discussion, I want to encourage everyone either in person or online to use the Slido code for the event, code HEPC, put questions that we can give to our panelists. So please use that tool. One of the comments, both for you, Judy and Colleen, you mentioned that you have gone through the SPA, and then you've gone through trying to be second in line for the 1115. Because there's so many lessons learned, and it is a long process to negotiate, perhaps with CMS. Is there additional guidance that you could receive from CMS that would be supportive for expanding these access to testing or treatment and preventative services that would be helpful as more states are trying to embark on but either through SPA or 1115 or other authorities?
I don't know. Do you want to start? I'm looking at a screen of you. I could start too.
We never know where to look with this.
Yes.
Yeah. So, Marianne, can you repeat that again in terms of the guidance that we would want to receive from CMS related to a SPA or an 1115 waiver?
I think the question is, what do you wish you had known when you first started working through the negotiation with CMS, where there was a lot of unknowns, and it's quite a process to get through, either through the SPA or through the 1115. What kind of guidance could be offered by the agency to other states that would be helpful to expand access?
So I'll start. I think CMS has really made it much easier for states to do now that they've gone through a state or two on both of these things. So for our SPA and our innovative procurement plan, we used a value-based template SPA that CMS has. So they made this template, gosh, about 5 years ago, really to try and encourage states to make different arrangements to have supplemental rebates with pharmaceutical manufacturers and kind of think outside the box of like, are we only going to pay for things that cure people? Are we only going to pay, like, do we get some kind of guarantee? And so we used that SPA template, and it was super easy. We got like approved, I would say in record time for most of the SPAs that we put in. We did have, I think from a while back, this pharmacy collaborative practice agreement. And so that wasn't really a barrier for us. And then I think the 1115 is always a process. I would say it probably takes a year or so for states to really work on and do. But the handy thing is once there is language out there that CMS has approved, you can just like copy, paste for your state. And so both California and Washington, you can copy and paste, and that won't be a thing that you have to negotiate with CMS. It was, that part was a very easy back and forth with CMS because they had already approved it for one state. And so I think that's a place that it's hard to get SPAs put through when it's like the first time and you're the first state trying to figure out what does this look like, but it's much easier after the first time or two to make that happen. And so I think CMS is really interested in this. They've been a partner with us. I think they've been a partner with California as well. And so, so I think it's getting easier. I don't know if you have thoughts about that in New York.
Yeah, so I'm a little bit removed from sort of the process of the back and forth with CMS, but I do know that New York was the first state for a harm reduction SPA, and obviously we learned a lot from that and reopened it and looked at it again because it was so narrow. And in terms of who could provide the services. I think from a hepatitis C, where I stand as a bureau director within a very large health department and advocating for, program, policy changes, surveillance, and data, and all that good stuff, is just to be involved in the conversation, right? To know what's happening within your department. So harm reduction, obviously, people who inject drugs, that is the priority population for Hep C for all of us, not just in New York State. So being part of that conversation and knowing, having input in terms of, so what should the benefit include? Is it just about, syringe exchange? Is it just about harm reduction counseling or education? And it's really important for us to get testing available in these programs. And we run a very large hepatitis C testing program, rapid testing with dried blood spot. We're waiting patiently for point of care diagnostic testing. But we know that it takes resources to do that testing. And so if that was a billable service, we know that revenue generated could go back in the program to provide support to carry out that service. Same thing for the 1115 waiver. Not intimately involved in sort of the details and the development, but was pulled into the conversation because we've done a lot of sort of promoting of the needs of people with Hep C and the populations and the settings. If you look at the New York State Elimination Plan, we've identified 5 priority populations and 5 priority settings that we need to focus our efforts on. People who inject drugs, people who are incarcerated, settings including state prisons and local jails are those priority populations and settings. And so that helped us be part of the conversation. And in our 1115 reentry waiver, which has been actually pulled out of the larger New York State waiver, so it's going to take us a little bit more time to get that implemented, Hep C is specifically mentioned. And so I think it's important for, programs like mine here in New York State, and I know my colleagues in every other state that do viral hepatitis work, is to be at the table in those conversations to see how you can work in hepatitis C into whatever parts of those SPAs or those waivers that are being written by your state.
Excellent, thank you. So I think both Judy and Risha made comments about going to where people are and how sometimes you're going to have to test in non-traditional settings. One of the questions that we've received from the audience is, what is the opportunity to use routine opt-out screening for hepatitis C in emergency departments as a way of reaching populations that otherwise do not access care regularly? So I'd like to hear about what are the opportunities, and then perhaps what are the kind of the resources that would be needed and the kind of level of coordination for follow-up as well.
Oh, sure. This is a great question for me to touch on. So my husband is actually an emergency medicine physician who oversees a Hep C testing program.
That was well planted there.
So maybe that was a plant, but I think it's really important because there are a lot of individuals, again, who are not having any other touch points with our health system. I think to the point made earlier, you know, we've had a decade now of waiting on people to come in to see us. That doesn't work, and so the paradigm has to shift. And so going to all of these other venues where we know people are, and the one place that people come when something is wrong is the emergency department. So it only makes sense to do opt-out testing. I'll say what I've seen in terms of my husband's engagement across the country on this issue is that, again, reimbursement becomes kind of an issue in terms of program, and then having staffing, again, to implement it and to track results, because a lot of people are being discharged from the emergency department. If you don't have the results, if it's a lab-based test, then you have to have staffing that can call those individuals and alert them whether or not, you know, they're chronically infected and need to be treated, and then work on linkage to care for them. And so, again, those are the pieces that you have to have in place. I will say in Maryland, one of the things our health department has done, that they have given some funding to emergency departments to be able to do some of that work. So again, I think that's something that states can do in terms of the dollars that would come from the federal government and how they invest them. I think it would be really important to invest in kind of emergency-based programs as well.
Great, thank you.
I'll say that in Washington, Harborview, which is our public hospital, has a pilot going on to do just that. There's one doc that is championing it, and they have found in their preliminary data that like 20% of the population, again, because it's sort of the safety net hospital, is positive for hepatitis C, which is extraordinarily high. And so there are barriers in terms of making this larger, in terms of the reimbursement and how does this fit in, that lag in the test delay, and how do you have follow-up for people, and what does that look like. And I would say, though, as part of a larger strategy, one of the other things that Washington is working on is initiation of treatment for opiate use disorders in emergency departments, and we have some sort of guidance on that. We've been meeting with different hospitals to say, hey, when these folks come in for whatever it is, like, you can start them on buprenorphine. You can start them if they're interested, and connect them up with care. And I hope that as that program gets rolled out and more hospitals start doing that the Hep C is sort of a natural fit with that, so that it can be paired, and then you have a place that you've already connected people to care in some way for their addiction treatment, and that could be a nice pairing, I think.
Excellent.
I'll just say one other thing. It also is a great venue for point of care RNA testing. So again, not having to call people back. And I'll say one thing that we've also tried for both HIV and hepatitis C is actually having a provider go down to the ED, one of our either a community health worker or sometimes a provider go down to engage the patient right then once we give them results as well.
Oh, yes. So, maybe we can get you a microphone.
Just two thoughts I want to throw out, and these are undoubtedly things you've considered already. One is, just going back to Don Borowicz.
Maybe wait just 1 second. So
sorry.
Thank you.
It's on. Okay. Don Borowicz work on dissemination of innovations in healthcare, 2003 JAMA, because there's always going to be early adopters, and then there's the great middle, and then there's the people who have to be dragged, kicking, and screaming. I mean, if you look at scurvy, people knew about citrus fruits back in the 15th century. Vasco da Gama's first voyage, 2/3 of his crew died from scurvy. Wasn't till the 19th century that became a standard. So it takes a long time. Supporting those early adopters like this provider you mentioned, God bless him or her, but also making them observable. And because the stigmatization is an enormous problem. The other thing I was going to say, and this is easier, poses a problem than solved. If it's more work, people won't do it. If it's less work, they will. And so I'll just offer that without any solutions.
But it does seem that this is such a right time for us to be learning from so much of the innovation that we're seeing at the states and the local levels, and how we kind of exchange that information. Still a lot of probably some lessons learned there. But thank you for those remarks. Absolutely agree. I think maybe just for a final question is, as you're looking at it, we've thrown out a lot of different ideas. Some of them are pretty big undertakings, perhaps. But how would you think about putting some real changes in delivery of care, especially when we're talking data or resources needed, within a 5-year timeline as being proposed by the national strategy?
So one thing I think that's super important that for someone who's been doing this work for almost 2 decades now, and with little federal support for the work that we've been doing, and do have state commitment around Hep C elimination and some dollars from state to support that work. I think one part, the sort of the 3 main parts with point of care diagnostic testing, that's sort of a no-brainer, especially when we need to reach the population that's most impacted by Hep C and not engaged in routine care in a traditional setting. And I think it might have been Judy who had mentioned, or maybe Risha, around the stigma, right? People who inject drugs will likely never go to a primary care site. So we need to bring the services to them, and we need that point of care diagnostic testing. But we also need the medication in these settings, and we need reimbursement in these settings to be able to provide the medication. And so the other thing too is that in the incarcerated settings, when I look at sort of that bulk buy of medication or that subscription model, because New York State does not have a subscription model, Medicaid was not interested. They felt as though they got the best price possible for drugs, and we do not have any prior authorization criteria. The local jails in particular, it's very challenging. And so with the 1115 waiver, if we can get free drug for local jails, there's a lot of interest in local jails. We're working with them now around testing. To me, that's a really important setting to bring treatment to. And so, but at the end of the day, we need to build capacity, and we need the resources to be able to operate the point of care test, to be able to prescribe the medication, to be able to provide those wraparound services. And so that's really key, is that states do get some capacity building dollars, because a lot of us have spent many, many years identifying the key partners, identifying the critical settings, where is the population. So we sort of know what needs to be done. We've just never had the resources to do it. And so now is a golden opportunity, when we have a cure and everything seems to be falling into place, that we also give that capacity building resources to the states so that they can implement the elimination plan.
Great. Thanks, Colleen.
So I'll echo some of the same comments. I just believe this is doable, and I'm sitting here because I believe it's doable. I think we are at a moment where we have the information from innovative projects that have happened across the U.S., that have happened across the world, and information from the Coalition for Global Hepatitis Elimination. So we know what works. We need the infrastructure to get there now. And so we're at that point, and I think all of the pieces are in place. There's been a lot of time focusing with all of the different federal agencies that would play a role. And so I think having this coordinated effort along with our states can really get us there, and it's a really great opportunity.
Great, thank you.
I'll agree, and I'll add, I think it's super important for public health and Medicaid agencies to work together. Our executive order did that, and we have quarterly meetings of like looking at the data and where are the gaps and what does this mean. How do we get community health workers out there? Sort of how do we bring the medical system and the public health system kind of together to treat folks with hepatitis C, that I think is really important. We've started about a year ago or so, we've started to give data about people with positive Hep C tests to our managed care organizations to have them help go find folks. And I think from my perspective, it's really, some of it is about resources and that time delay of it needs a rapid test and it needs the medication right there at the point of care. And especially for settings that have fewer Hep C cases, I think folks are really nervous to have a medication sit on the shelf for a long time, whether you're an ER or whether you're a pharmacy. And so then people get mailed their medication or they have to come back like one more time. The better we can like shorten up those distances between things, I think the more rapid progress we'll make. And I agree, it's a very exciting time to work on curing Hep C.
Wonderful. I want to thank the panelists for this great discussion.
Thank you all very much for an excellent discussion. I'd now like to very quickly introduce our very busy next speaker. Senator Chris Van Hollen from Maryland has been deeply involved in a range of healthcare issues, affordable prescription drugs, better primary care, greater access to effective care. Senator Van Hollen is also part of the leadership on this effort to address hepatitis C elimination. Thank you for joining us today, Senator.
Well, thank you. Thank you, Dr. McClellan. And it's good to see you, even if it has to be virtually after this time. Look forward to reconnecting in person at some point soon. And really thank you and the Margolis Center for all the work that you're doing. And I remember well the times you and I spent together when you were over at FDA and the Centers for Medicare and Medicaid Services. Proud to say both of them are the great state of Maryland. And to all of you joining this important conference, thank you, scientists, educators, policy experts at the Margolis Center and beyond. I think you know well, this is the purpose of the conference. We're at a very exciting time in our longstanding battle against hepatitis C. We all recognize that it's one of the most common lethal infections in the United States and causes daily harm to Americans from all walks of life, claiming over 15,000 lives each year, affecting over 2.4 million Americans. And the cases have doubled in the last decade, the reported cases, and we know that it is likely very more because of limited testing capabilities and resources to prevent and cure this disease, meaning there are likely a lot more suffering who are unknown to us. So for these reasons and many more, defeating Hep C is a priority for many of us here in the Congress. And the good news, as you all know and have been talking about, is we can do that. We can defeat Hep C. I was very pleased that President Biden in the fiscal year 2024 budget proposal included resources for these purposes and shared the commitment to identifying and curing this disease through the goals outlined in his National Hepatitis C Elimination Program. And I am working on a bipartisan basis with colleagues in Congress to accomplish that. Senator Bill Cassidy and I have been in regular communication and hope to have something ready to introduce soon. And of course, our guiding light here has been Dr. Francis Collins. I want to give him a big shout out and thank you for his commitment and perseverance on this really important health matter. At the center of our plan is the subscription model to obtain and distribute the cure at a bulk price. As you all know, having drugs on hand is not enough alone, however. So we build out the public health infrastructure through primary care, community health centers, opioid treatment programs, and correctional facilities to test, treat, and coordinate care for patients. The proposal would also increase the Hep C surveillance and outbreak detection to inform and improve our response. With this plan and the investment, we have an opportunity to save 24,000 lives over the next 5 years, and also save $8 billion over the next 10 years. And Mark, as you and others know, showing CBO, the Congressional Budget Office, that we can realize those savings, I think will be very important as we move through the legislative process. And I think all the analyses I've seen shows that that is a very real possibility and very likely. This, of course, if we pass this, would be a milestone for those battling Hep C. It would also, in the end, be a net plus for the American taxpayer. I should mention that another component of our Hep C response is the rapid point of care testing, so that a patient can get diagnosed and prescribed their treatment in the very same visit. And there's a point of care RNA test being used in Europe, and hopefully the FDA, where Dr. McClellan used to lead, can validate its effectiveness for use in the United States. So I know all of you at the center are working on a framework that aligns with this model to bolster our fight against Hep C. And I do look forward to continuing to work with you and partner with you as we try to move this over the finish line. I will say, as a member of the Senate Appropriations Committee, as we move forward on this initiative, I'm also committed to securing the necessary funding so agencies like the CDC and the NIH have the resources they need to prevent viral infections like Hep C. So let me just, in closing, thank all of you at the Duke-Margolis Center for Health Policy. Dr. McClellan, thank you and your team there. And I do have a vote on here in the United States Senate, but I just wanted you to know, and I appreciate your letting me zoom in here. I wanted you to know that we are focused on this in the United States Senate. The challenge, as with so much else these days, is for us to identify what legislative vehicle we can put this on once we have a final product. We're still trying to finalize the details, but I really hope that we can do that within just a few weeks. And then hopefully we can look to early next year to find something that we could put this legislation on so that we can expedite its passage, get it to the president's desk for signature. To do that, we look to all of you for your continued support and input. Many thanks to all of you for being, key members of the team in achieving this very important healthcare result for Americans, and indeed for as a model for others around the world. So thank you all.
Thank you. Sir Van Hollen, thanks so much for joining us today. You've got to get back to vote. We get to take a break at this point. So we're going to reconvene for our next session, focusing on federal levers, Medicare and otherwise, at 3:10. But enjoy the break in the meantime. Thank you.
Thank you.